start by asking people to talk about your part in doing this and meeting your specific place in this. And then I really want you to be focused and specific and maybe not politically correct in talking about what needs to happen, not only here in Los Angeles County, but in Orange County, especially in the other counties that are not necessarily open to harm reduction approaches, and how as a regional approach we might work with our brothers and sisters to move services to, say, county edges, or be able to work across jurisdictional areas to be able to get harm reduction to people who may not have access. So that's a mouthful. So Gabriel, you want to start?
Sure. So first of all, thank you everyone for coming to this space and for inviting me to be on the panel. I have a whole series of notes here on various things that are not only barriers, but things that we're specifically working on to address specifically PrEP access in Riverside and San Bernardino County. I'll put it into kind of two buckets, just so I can condense these notes down. And the first one is kind of the policy barriers, because funny enough, in running my agency, I actually found that there were a lot of policy barriers for us to being able to provide PrEP. And then the second one is these kind of really deeply rooted existing stigmas around specifically PrEP usage amongst gay men of color. And I'm going to frame my conversation amongst Black gay men, which is the population I work closest with. But really, one of the biggest challenges that we have found is not only trying to overcome some of the barriers around infrastructure. We are a 27,000 square mile region between Riverside and San Bernardino. We're larger than 5 states in the union. So this makes physical infrastructure, actually having a building, a place where someone can go. I mean, even in the wake of teleprep, you still got to have a room, right? There's still got to be 4 walls somewhere. And being able to find access to transportation to be able to get clients sometimes up to 2 hours in transportation can be a very big challenge. So one of the things that we do is we work really closely with a lot of our providers to find loopholes in calling Lyft transportation. So for a perfect example, IEHP, which is our local Medi-Cal health plan, allows for us to call door-to-door Lyft transportations for clients through our mental health clinic. My agency is credentialed under IEHP for mental health. We don't do primary care. We have a rapid start PrEP clinic, but we don't do primary care. We're not a PCP. We're a small community-based organization that's growing, but mental health has been one of the major areas that we've kind of grown and expanded, and we're able to call our clients Lyft transportation door to door using IEHP, but coding it as a mental health visit. And so we have a psychiatrist on staff who actually is our PrEP prescriber. So he's actually credentialed and he's listed as a mental health provider, but he has the CBT codes to be able to call and qualify the client for door-to-door transportation for their PrEP visits. So that's one of the things that we do to address some kind of the infrastructure barriers around getting clients to different locations. The other one is that there's often a Pcp referral requirement for us. And the challenges with clients, particularly when you're talking about folks who may be undocumented, folks who are highly transient, as Dr. Edwards mentioned, transience is a really big thing in the Inland Empire. There are folks who receive care in Los Angeles, but they live with their auntie in San Bernardino, but their boyfriend is in Palm Springs, and they go into the white party on the weekends, right? And that is about, on average, 2.5 to 3 hours of a physical drive, and it can be up to 8.5 hours in public transportation. You can actually get from the Fenway Institute in Boston to us helping us in Washington, D.C. faster than you can from the AIDS Healthcare Foundation in San Bernardino to the Desert AIDS Project in Palm Springs. And that's a real presentation I did, so that's how I know that for sure. And so those are some of the really big structural physical barriers, is transportation, physical location, these policy requirements that require us to have our clients in medical home. It limits our ability to be innovative. We're not able to do PrEP rapid start if we're not wanting to reimburse for the service. And then the second bucket, and I want to give room for my colleagues to also speak, is stigma. And I have 5 things listed here. I've been doing a lot of PrEP consultations with Georgetown around the country and meeting with a lot of Black and Latino gay men. And there is still a very deeply ingrained distrust for the institution. And I use the word institution broadly because it could mean TruEvolution. There's a distrust for us. There's a distrust for FQHCs. There's a distrust for anyone that's a medical provider. There's still elements of distrust. There's distrust with industry. And I think one of the greatest conundrums that I was like, I don't know how to solve this, that I really didn't think that it was an issue in my generation, um, is this idea around trusting pharmaceuticals, trusting medication, the trusting of the therapies. And I think being able to kind of re-educate our population to not only the institution, but the safety, security, and viability of the pharmaceutical and the therapy, there's some education that still has to happen around that. So I'll pause there. But those are my two buckets.